Well, hello everybody, and welcome to our session on glaucoma grand rounds, how not to crack under pressure. My name is Mark Dunbar. I'm the Director of Optometry at the Bascom Palmer Eye Institute in Miami, Florida. I'm joined today by Rich Madonna, who's the Professor and Chair of the Department of Clinical Education at the SUNY College of Optometry in New York City, and Danica Morelli, who's the Clinical Professor and Director of Ocular Diagnostic Services at the University of Houston College of Optometry in Houston, Texas. So we're going to take a little bit of a different approach to utilizing technology and OCT to manage glaucoma. I think all of us would agree that OCT has really been a game changer in providing additional information, allowing us to really have more pieces of the puzzle to really look at in deciding, does this patient have glaucoma? Is this patient getting worse or progressing? And so I think it's been really a key piece of information that allows us to put all those pieces of the puzzle together. But I think as good as technology is, at the end of the day, I think you still have to be a doctor. You still have to look at all the information that you have available and still have to make sometimes tough clinical decisions. And sometimes when you're trying to answer those questions, does the patient have glaucoma? Is this patient getting worse, etc.? Sometimes you're not going to be able to answer that on a single visit. And sometimes it really takes a little bit of time to look at the data over time to be able to put that information together, to be able to answer those questions. So I want to kind of dive into a little bit of this idea of what is red disease, what is green disease, and then really putting those two pieces of the puzzle together, and then ultimately being able to talk about progression. So there's a few fundamental OCT and glaucoma rules. One of the key ones that I talk about in all my lectures, and I'm not sure everybody really does it, but really this key idea that when you're going to do an RNFL scan, I think it's important to not just do one scan, but really do at least 2 or 3 scans when that patient is sitting in the chair. I think the main reason is, number one, it gives you that retest variability, which if you're going to repeat a test over and over, that variability should be up to 4 to 5 microns. But the reality is, depending on the patient, depending on the circumstances, depending on the anatomy, the operator, etc., it can be more than that. And the reality is, if you only do one scan and use that scan to make your clinical decision, it's very difficult because at the end of the day, number one, is it an abnormal scan? Number two, is this patient getting worse over time? And I think to some degree, you need to know what is that variability, that intra-scan variability on that first test or second test and so on. And so that's really one of my main fundamental rules. I can't imagine making a decision on a glaucoma patient if I've only got one RNFL scan to base that decision. I think the other reason is that on your follow-up visits, at least with the Cirrus, you're able to use 2 of those scans as your baseline when you're doing your guided progression analysis. And I think we'll see that as we're going along, at least in the case that I'm going to present here in just a few minutes. I think the second rule that I always ask myself when I'm looking at a patient, just picking up my 90, looking at an optic nerve, the question is, can the RNFL scan of my patient of this optic nerve really be applied to the normative database? And I think we recognize that that normative database is predicated on a normal age match population. So there's some situations where you're not able to apply that. So the patient who, for example, is a high myope, maybe a -10 or a -12, doesn't mean I wouldn't use my OCT and look at the RNFL, but I think you have to be careful when you're applying this normative database. A tilted disc, an extremely large optic nerve or an extremely small optic nerve. Again, you probably shouldn't try to apply the normative database, even though, again, sometimes you can, but I think you always have to keep that in the back of your mind. A patient who may be 14 or 15 who's got suspicious nerves, and you do the OCT and you'll find out that all the printouts are white because they were not part of the normative database. So those are really a couple of the questions that I ask myself. And of course, we know when you get a green reading, there's a 95% probability that the scan you're looking at is normal. When you get the red, we know that it's a 99% probability that the scan is abnormal. Again, compared to that normal population. But again, the idea, just because if you get a red on the RNFL doesn't necessarily mean that the patient has glaucoma. And it goes back to that original thought that I had. It's sometimes you've got to look at all the information, the pressure, the patient's nerve, your visual field, and the data that you get from the OCT and ask yourself, is it really abnormal? Does this patient really have glaucoma? And so with that, let me dig into my case. This is a 68-year-old African-American male who was inherited to me in 2018 or 2019. And so this is when he comes to me for glaucoma follow-up on one of the visits. It's February 2019. And as I said, he'd been diagnosed with pre-parametric glaucoma back in 2013, and in fact was originally seen in 2012. They thought he had pre-parametric glaucoma. The pressure was high enough that they were concerned, so they started him on timolol. Eventually, over the course of a few years, he was eventually on COSOP and latanoprost, and this was back in 2015. And so the remarkable thing about this guy is he'd been followed faithfully every 6 months. He comes in like clockwork. So when I'm seeing him, the visual acuity is 20/20, the pressures are 13, and he's got a cup to disc ratio of about 0.75. And I'll show you what those nerves look like in just a few seconds. Here's his OCT scan. And this is scan 1. I'll show you the second scan, and I told you we always do 3, and I'm not going to show you all 3 of them because the first and second one are pretty similar. But you look at the right one, and I think you can see that it looks relatively normal, especially when you're looking at the clock hours and the quadrants. When you're looking at the deviation map, for the most part, it looks pretty normal. I think when you look at the left eye, there's a little more suspicion. You can see in the quadrants and the clock hours, we do have some red. You see on the deviation map along the inferior arcade, maybe what could be an RNFL defect. You see this kind of suspicion nasally that I think is a little concerning, and we'll talk a little bit how to interpret that in a few seconds. This is the second scan on that visit, and then I've put both of them side by side so you can kind of look at them and kind of compare, and you can see that they're actually pretty similar. So the question is he stable? So remember, he's been followed since 2012, started on glaucoma in 2013, and on that visit, when they started him on medication, his pressure was 20 and 22. They had considered a target of about 13 and 14, and of course, on the visit that I'm seeing him today, he was a pressure of 13, so he was really right at the target of what you would want. So again, the question is he stable? And then the second question is his pressure adequate for whatever level of glaucoma we think he has? Well, this was him in 2012, and on that visit, his pressures were 19 and 22, and I think you can look at those nerves, and all of us would be a little bit suspicious. They do look a little fairly round nerve, fairly moderately large cup. You don't see any disc hemorrhages. You kind of look at the anatomy. I think it's, again, just by looking at it, I think all of us, given those pressures, would initiate a glaucoma workup that would include an OCT and a visual field. Here was that scan in 2012, and you can say that it looks pretty normal in the right eye. We've got kind of a borderline in the superior quadrant in the right, in the superior and inferior quadrant, a little borderline. I'm going to draw your attention to the left eye, and kind of that area on the deviation map at 12 o'clock may be a little bit suspicious, but again, you look elsewhere and you don't really see any typical areas of thinning, although I think we'd all agree this is not a robust RNFL thickness map by any means. And then you can look at the quadrants and clock hours. And again, I think certainly suspicious, but let me show you his visual field. And the right one, which is on our right, I think you're looking here, it looks pretty normal. The left one, we've got a few points within that central area, but again, first time field. I would probably pass this off as being normal in light of the OCT. And so I think, again, you put yourself back to 2012, and I think we would agree he is a glaucoma suspect, at least based on the cup to disc ratio. The visual field being normal, OCT probably normal, but probably suspicious enough that we would observe this patient at least every 6 months, and that's exactly what we did with this patient. So here he is about 6 months later, and whoever was looking him at that time had thought there might be a change. They repeated the pictures, and then when they looked at the pictures, they thought the cup to disc ratio had changed. And I'll allow you to look at that in a little bit as well. But they had thought the appearance of the optic nerve had changed from the year before. And we're looking at the right eye, and again, you can maybe look at it, and a little bit of a different resolution from the picture from 2012 and 2013, and it's maybe hard to say, has it changed, has it not? Here's the left eye. And again, I mean, I would look at it and I think it's fairly similar to me. Difficult to say there's a change just based on those photographs. But again, the provider that was seeing him at that time thought there had been a change. Here's his visual field, by the way. And you can see he did a little bit better on the visual field. And they both look normal, right eye and left eye. And this was the OCT maybe a few months later. And you're going to look at kind of what we had seen back in 2018. All of a sudden, what looks like perhaps a change. The right one about the same, the left one maybe not so much. And again, this is the visit that the pressure was a little bit higher, 20 and 22. Remember, they thought there was a change looking at the optic nerve and comparing to disc photos. And they had at that time put him on timolol, and his pressure went down nicely to 15. And this is the second scan. And what I'm going to do is, again, show you both of those scans. And I think you're going to see, at least in the left eye, that there's some variability, right? You look especially in the 5 o'clock position on one scan, at the 7 o'clock position on the other scan. Clearly, there's a little bit of variability. You look at the deviation map, and again, maybe some variability as well. Let me show you the 2012 to 2013 scan and kind of compare them. And maybe you can understand when you look at it, perhaps, why it was thought that maybe this patient had progressed. Remember, not only based on this OCT, but looking at the nerve, they thought there might be a change. And then I wanted to kind of show you, again, 2012 to 2013, looking on the individual clock hours, and then even that quadrant inferiorly. I think you can see that there's a little bit of a difference between that 2012 to 2013. And so the decision was, well, by the way, looking at the visual fields, they're still normal on that 2013 visit. So they had thought the patient had preparametric glaucoma, and as I said, they started him on timolol twice a day in both eyes. And so as I said, he was really very precise in terms of coming in. He would come in on the dot every 6 months. You can see in 2013, timolol eventually switched to latanoprost. In 2014, they added Cosopt, and you can see in a couple of the visits, 15, 16, and then 17 and 18. And really for the next 5 years or so, 4 or 5 years, he was down to what they wanted the target pressure to be at about 11 to 13, and he kind of maintained that. And so here he is in February 2019, and this is, I guess, one of the visits that I had seen, and maybe the original visit. Pressures are 13, he's at the target. Again, you're looking at the OCT, and again, when you compare that 2013, not the 2012, but the 2013 to 2019, and again, when you look at maybe that 5 o'clock position where on one of the scans it was a little bit of abnormal, and again, looking at the 7 o'clock and 8 o'clock position, there may be a little bit of variability. Looking at on your deviation map at that inferior kind of temporal on the deviation map in 2019 compared to 2013, wondering is there a change, etc. And again, I kind of highlighted that. But I think what jumps out at you is when you look at, why are we having the variability? And when you look at the thickness map, you see this, what really looks like algorithm failure. And whenever you see that black on a deviation map like that, I think it jumps that this is a failure in the algorithm. It shows up, on this 2013 scan to 2019 scan where you see this kind of area on the deviation map that looks abnormal. And even just looking at your T-SNP curves on the bottom, you can kind of see you've got an area there where it's completely abnormal when you're looking at that T-SNP curve. And so again, I took 2 of the scans from 2013, and I think you can see the variability that we saw at the 5 o'clock position from the 7 o'clock position, and then kind of in a sense compared that to the 2019. And so again, why do you get that kind of variability? And I'm going to show you what his ganglion cell analysis is in both eyes. I think you can see it's a little bit thin. And again, this doesn't tell me a whole lot because I think there's generalized thinning. So I tend to discount a ganglion cell analysis on a patient like that where it doesn't really quite fit everything that I'm looking at. And again, we can talk about that a little bit with our audience. The left eye, maybe temporally, you could wonder, is that a little wedge-shaped defect? It's hard to say when there's so much thinning. But here's his visual field in 2020. And once again, I think you'll kind of see the left eye and the right eye, what I would call pretty normal. They're pretty reliable scans. And you compare that 2013 visual field to the 2020 visual field. Again, when you look at the left eye, even though maybe a little bit of a depression on the deviation map, when you look at the pattern deviation, again, I would say that's pretty normal and just part of the long-term fluctuation that sometimes we see when we're managing glaucoma patients. You look at the visual field index scores, certainly pretty good, 100% on that 2013, 98, not quite 100%, but still certainly pretty close. And so it goes back to that original question, right? Is he stable? Is his pressure adequate? Has he gotten worse? Remember, we started at a Tmax of 20 and 22, and our target being around 13, 14, certainly are within that range. But when you look at the totality of all that information, when you look at the variability on the scans, I think maybe the bigger question is, does he even have glaucoma? And again, when you were looking with your 90 or 78 through a dilated pupil, he had probably one of the largest, most dense Weiss's ring that I have ever seen. And it wasn't subtle. And I think that density of that Weiss's ring that's floating just above the optic nerve is really responsible for the variability on his OCT scan. And you can kind of see that when I highlight it there. You're looking, especially on the two scans from 2013 at the 5 o'clock position, you've got over 40 microns of variability. And that's partly because that PVD, that Weiss's ring, moves around and it just catches the scan, and you get some abnormalities and variation in the OCT scan. And so when you look at kind of the GPA, the guided progression analysis, I think you look at the top, especially on that baseline, you don't see it. But then when you're looking at those other scans, I think you can see that algorithm failure that kind of follows you on most of these other scans. And again, I think just almost not completely invalidating the OCT, but really accounting for the variability that you see on the scan. Again, the right eye looks pretty normal. There's really not a lot of change, especially when you're looking at the inferior quadrant, superior quadrant. I think it's certainly within a tight range that you would want. There's no question he has suspicious optic nerves, but when you look at everything together, I think this is ultimately red disease. I think the PVD is causing the variability on the OCT scan. And again, this started with a glaucoma specialist. It was inherited by my optometric colleagues. And when I started looking at all the information, the question is it really glaucoma? And I think the answer is no. And so then the question is, well, what do you do now? I didn't want to stop all his glaucoma medications, especially considering he's been taking these medications for the last, 4 to 5 years. So we stopped the COSOPT, and we're going to continue him on latanoprost. I'm going to bring him back in 3 to 6 months. We'll check the pressure. We'll kind of follow him as we've done, but really maybe begin that stepped approach of maybe stopping therapy if everything proves to be stable. And so with that, I will turn this over to Danica to talk about her case.
Mark, I just had a concern regarding the macular cube scan in his left eye, and you pointed out that he may have a inferotemporal change there, and I think he may, but you said it very nicely that he's got overall thinning, so it's hard to tell. But when you look at enough of these, you do get that sense sometimes, whether we're calling it an inferotemporal wedge defect or a nautilus sign or a squeegee or a windshield wiper, or nobody's really come out. Danica, I'm waiting for you on that one. I think maybe there's something there, and that's not to say that I think that it's a clear cut or it's a layup, but I might consider doing a 10-2 on this patient because it does give me that impression. But my overall sense of this case is I think you make wonderful points that this could have been someone who was overtreated. And actually, I'm going to talk a little bit about some of the same things, so I'll just hold off from there.
Yeah, and I think, to add to this, Mark, when you have a patient that I don't want to say that they jump the gun, but if you start your patient on therapy and you continue your patient's therapy for 6 years or 10 years and they haven't really shown any change, you don't really know. Did you just do a great job of managing the patient, or did this patient never have glaucoma to begin with? And so I think that it's worth doing those things that you talked about, which is get multiple scans, make sure that you really are dealing with glaucoma, make sure that you have corroborating evidence that the patient does in fact have disease.
Well, good. Well, thank you guys. I'll keep you posted. And with that, let me turn this over to you, Danica.
Thanks, Mark. So sort of the opposite of what you just talked about is what's known as green disease, which is when your patient's OCT scan looks very normal and very green. And so we have these knee-jerk reactions that red is bad, green is good. And we need to be a little bit more sophisticated when we're looking at our scans. So I'm going to talk to you about one of my very favorite cases because I think it really just always makes me pause and say, Danica, you have to look at the scan really carefully. You can't just look at these stoplight colors. So 61-year-old Hispanic man who got referred to me for a glaucoma evaluation because he has big CD ratios. Pretty typical referral that I get in my service. His ocular history is unremarkable, and his medical history is significant for hypothyroid disease. He takes a thyroid replacement for that, and he's pre-diabetic, just managing with exercise and diet control. No glaucoma in his family and nothing else to really worry about. Visual acuity was 20/20, pupils, EOMs, confrontation visual fields normal on his exam. Slit lamp exam was normal with no signs of secondary glaucoma, and his gonioscopy was open to the ciliary body band, 360 degrees with no abnormal findings. Pressures when I saw him on this first visit were 18 and 15. Here's his optic nerve. Here are his visual fields. And of course, what everybody wants to go right to is the OCT. So I'll let you just kind of look at that OCT for a second and think about what you think about it. And then I want to just go through it. You know, at first glance, when you look at these thickness maps where we expect to see these, really bright, hot colors of yellows and reds in the superior and inferior bundles, he looks super thick. And if you look at the average nerve fiber layer, he's very, very thick, over 100 microns thick. We don't have reds, yellows, and greens in this neuroretinal rim thickness because his disc is so large. The disc area is 2.71 in the right eye, 2.59 in the left eye. So we're dealing with really large optic nerves. And so, Mark, that kind of goes back to your rule number 2, which is, can I apply the reference database or the normative database to this patient? And because his nerves are so big, I don't think that we can. We can still look at the nerve fiber layer. We just can't necessarily use those red, yellows, and greens. I think the kind of the money shot or the most important thing to look at in the whole RNFL scan is the superimposition of the nerve fiber layer thickness. And when you look at this, his peaks are really, really high. He has a lot of nerve fiber layer. But one thing that I'm drawn to is this, especially in the superior sector, this asymmetry between the right eye, which is still well within the green, well within the so-called normal database, but which is significantly thinner than the left eye. If we come down to our quadrants, and honestly, I don't look at this too often when I'm looking at these scans, but you'll see superiorly, he's got a measurement of 115 microns in the right eye compared to 159 microns in the left eye. And, glaucoma is a disease of asymmetry. And what I'm always looking for is when I look at this T-SNP curve, I want to see that my patient has thickness superiorly and inferiorly. And I want to see that these curves really sort of superimpose on one another very well. So you have to ask yourself, is this glaucoma? You look at his nerves, I don't think that you say, gosh, these nerves look super glaucomatous. You look at his visual fields, maybe you say, it's just a first-time visual field. You look at his OCT, and I think that on first glance, just see lots of green and even white because he's so thick. But when we go and we look very, very carefully, I would say that there are a lot of indicators that this is likely glaucoma. The first thing that I notice is even though we've got some yellows and reds, which is what we expect to see, there's what looks like maybe the development of a slit defect right here. And certainly the thickness superiorly in the right eye doesn't look as full and as thick as it looks in the left eye. I already talked about the asymmetry in the T-SNP curves and the asymmetry in our quadrants and clock hours as well. I love this plot. This is the structure function plot. And I love this because it really lets you sort of put things all together. And so in this RNFL thickness map, you really see that asymmetry between the right and left eye superiorly. And we see this is a different visual field, just a somewhat later visual field, but a well-defined inferior nasal step partial arcuate defect, which really correlates very well with this defect that we see superiorly. If we go back to that very first visit and we look at his right optic nerve, there are a couple of other things that I think you could sort of blow through on your clinical exam if you just have a lot of patients waiting, you're trying to get through your morning. But if you look at this superior rim here, I think that the superior rim is a little thin compared to what we would expect it to be. And we also have a very small optic disc hemorrhage right here. Everything is really adding up. Superior optic disc hemorrhage, superior rim thinning, superior nerve fiber layer loss with corresponding inferior nasal visual field defect. And so this is a case where I always use this case with my students, and they always say, no, this guy doesn't have glaucoma because those OCTs are so thick. Everything looks so normal until you really start to dig down and look a little more carefully. So before I move on to progression, I guess I would ask Rich and Mark if you have any comments about this case.
I think you handled it perfectly because I agree with you. There is a huge difference between the right and the left eye. And so when you look at the T-SNP curves when they're superimposed, I think one of the most important things to do when you're looking at an OCT is to look at the T-SNP, or now we're starting to see Enston curves, and look at the symmetry between eyes, which you did beautifully, and you pointed that out perfectly. So I would agree with you. I think that this is a patient who, despite having very thick retinal nerve fiber layer, probably does have relatively early glaucoma, and he's young and probably deserves treatment, which I think is what you did with him.
Absolutely.
I agree with Rich. I think, the fact he's got a disc hemorrhage, and how subtle is that disc hemorrhage? I always, when I see these type of patients, I bring up the fact in the OAT study, I think 86% of the time disc hemorrhages were missed by the provider, OD and MD, but picked up by the reading center. And this is, you can see why. This is one of those examples where that is such a subtle disc hemorrhage that you could easily miss it. And again, I think everything adds up very nicely. So it's a great case, Danica.
Yeah, I think that when I'm talking to my students about looking at the nerve, and by the way, one of the other things I think this case is really good at exemplifying is that, we can't relegate our clinical exam to an afterthought. Our first attempt at trying to decide whether a patient has glaucoma really has to be a look at the optic nerve. And when we're looking at the nerve, looking for things like rim thinning, looking for disc hemorrhages, you have to really be intentional and say, don't forget to look for that. Don't forget to look for the peripapillary atrophy. Don't forget to look for the subtle nerve fiber layer defect, which we actually can see on this image as well. It sort of looks like a blood vessel, but it's actually just a slit nerve fiber layer defect. So this really also, I think, exemplifies the fact that our clinical exam is really important in the decision-making process.
You have to be a doctor. Right?
You do. It is not the answer box. And OCT is a great tool, but it's not going to tell us what we have to tell ourselves.
We work typically in secondary care type clinics, but the decision to get patients to secondary care, and if we can just say we'll include getting OCTs and visual fields, has to be made at the primary care level. These patients don't get into the glaucoma surveillance system, if you want to call it that, unless somebody makes the appropriate call on the front end. And that's what I've been trying to bring home to primary care doctors. They have the harder job. They've got to get the whole thing started. So we cannot get rid of our clinical exam unless there comes a day where the diagnostic paradigm changes completely and everybody gets an OCT and a visual field on the front end, and we don't look at nerves anymore. And I don't think that's going to happen anytime soon.
Yeah, great point. So I love the way you say that, Rich, about the, what do you call it, glaucoma surveillance system?
Yeah, I made that up.
I love that because it actually leads right into the next topic, which is progression. And, I think we spend a lot of time in the diagnostic bucket, looking at a patient, looking at a single snapshot in time and saying, does this patient have glaucoma? But once you've said, okay, this patient is at least a legitimate glaucoma suspect, or you've made the diagnosis of glaucoma, your whole mindset shifts and you go into the mindset of watching for progression. Because in those glaucoma suspects, that may be what makes you decide, yes, I'm going to go ahead and treat this patient because I've seen something that makes me think there's been a significant change. So I'm going to talk a little bit about progression determination. And this is really whether you're following a patient as a suspect or if you're treating a patient who actually has diagnosed glaucoma. And so I think that detecting progression is a lot harder than making that decision about whether or not a patient actually has glaucoma. And I'm going to talk about a few things. There's not that many words on this slide. I want to get into a case, but I want to go over a couple of terms and a couple of thoughts before I get into a case. So we can look at progression determination really in sort of two different ways. And the first way is called event analysis. And I like to think of event analysis as just a yes or no question. Has today's test changed significantly from the baseline? So it's really kind of yes or no. And so that's going to use what we know about test-to-test variability. So you could talk about that in terms of a visual field. How much fluctuation do we expect a patient to have from test to test? You could look at it from an OCT standpoint. What's the test-to-test variability and measurement? And event analysis, that yes or no answer is going to get flagged or triggered when a patient exceeds the expected amount of test-to-test variability. The second way to look at progression is to look at how quickly is a patient changing. And so in general, we're going to look at event analysis, the sort of yes-no question earlier on when we have fewer tests for comparison. And then we're going to transition into trend analysis, or how quickly is this changing? What's the rate of change when we have more tests? So trend analysis is going to take some metric of your visual field or of your OCT, and it's going to create a regression line over time and tell us what is the rate of change. One of the things you have to think about when you're trying to figure out if a patient is progressing is how quickly are you going to do your tests. So with a visual field, for example, it's probably going to take 5 or 6 visual fields before you're going to be able to say with certainty that that visual field is showing progression. If you're only doing your visual fields once a year, that means it's going to take you 5 or 6 years before you're able to say, yes, this is change. And so I think that we've learned over the last few years that you really need to kind of stack the tests a little bit in the beginning. So I try to get 6 visual fields in the first 2 years following diagnosis of glaucoma, or following, designation that this patient is in fact a legitimate glaucoma suspect. And it sounds like a lot. It sounds like 6 visual fields in 2 years. Are you kidding me? But it's really not that much. It's a baseline test and a second test fairly shortly after, and then one at 6 months, 12 months, 18 months, and 24 months. After that 2-year time period, you should really be able to tell if this is one of those patients who seems to have aggressive glaucoma. Is this a patient who's changing very quickly? And then the last thing that I'll talk about is resetting a baseline, but I really need to get into the case to be able to show you that. An 86-year-old Hispanic male followed as a glaucoma suspect from 2008 to 2012 due to the presence of pseudoexfoliation in both eyes. Now, initially in 2008 and through about 2011, his intraocular pressure was normal. In fact, it was in the 14 to 16 range, maybe 17 on occasion. We were just following him with serial visual fields, OCTs, and pressure readings. And then in 2012, his pressure started to go up. He got up to about a pressure of 24. And we decided that it would be beneficial to lower his pressure if he could tolerate it. So we started latanoprost in 2012. Now, these were his initial optic nerve photos from, I think, 2008. And you can see that there's a difference in cup size, but there's also a difference in disc size. And Mark was talking about that. So with a bigger optic nerve, we expect to see a bigger cup, which is what we saw in this patient. These were visual fields from 2010, so I guess we had at least some data from 2010. And again, you see a little bit of mischief going on in the left eye nasally, but nothing that really screams glaucoma. And it actually wasn't the left eye that we were quite as concerned about. And then this is his one of his initial OCTs. And I think when you look at the thickness map, you don't see a lot of difference between the right and left eyes. The average nerve fiber layer thickness is on the lower end of the normal range. But when we come down to the T-SNP curves, maybe there's a little asymmetry here inferiorly in the right eye. That may be why we see this little area on the deviation map, but really nothing that made us, an older gentleman, really want to start therapy until his pressure began to get elevated. Now, if we fast forward a little bit, we can look at his visual field GPA over time. And so these are his first 2 visual fields, 2009, 2010. And if we come down to the most recent visual field, February of 2019, and we come over to this plot right here that has the triangles. This is our event analysis. This is sort of our yes-no question. Is today's visual field worse than the baseline? And what we'll see is a number of points, I'm pointing them out with the arrow, where we have these open triangles. Each of those points has exceeded the expected amount of test-to-test variability one time. Adjacent to those, we see some triangles that are halfway filled in, which represent points that 2 consecutive times have exceeded the expected amount of test-to-test fluctuation. And then far over on the nasal side, we have 3 points that are completely black. And that means that 3 consecutive times these points exceeded the expected amount of test-to-test variability. That's going to give us this likely progression message. So this is all event analysis right here. If we go up to our trend analysis, which takes the visual field index, the percent of normal vision for his age, and we look at that over a very long time, actually 10 years, we can say it does have a downward slope, but it's not really changing very significantly. So this is a case where our event analysis says, yes, there's been a change, but our trend analysis says, yeah, there's a change, but it's a pretty slow change overall. If we go to his right eye, though, and it's the same type of progression analysis. So here we're starting in 2008, going to 2018. We see what I think of as a much more significant event analysis for a couple of reasons. One is we have more points that have changed on 3 consecutive tests, but also because they're in a much more typical location for glaucoma damage. And we see really the development of a well-defined nasal step and partial arcuate defect here. When we come up to our trend analysis, we see that yes, his trend has changed. It's still relatively slow, a little bit faster than we got in the left eye, but still relatively slow. For a gentleman this age, maybe this isn't really significant change. If we look at his OCT, I think we see something a little more concerning though. So again, we'll start with his right eye, 2012 to 2018. For the OCT, the places where we can see event analysis are right here. So anytime we see yellow pixels, any place that we see yellow pixels, those are changes that exceed the expected amount of test-to-test variability on a single test. And then when those areas are repeated, they'll change to red. So we have both inferior and superior areas where we expect to see change in glaucoma that are saying, yeah, this patient has changed from baseline back in 2012, 2013. We can also see this event analysis down in our superimposed T-SNP curve. So we see a little bit of change superiorly and a more significant repeatable change inferiorly. For our trend analysis on the OCT, we can see that average, superior, and inferior nerve fiber layer thickness has changed significantly. And we see a very similar thing in the left eye. One of the things I want to draw your attention to, though, is this gap. So we have this gap here from about 2013 to about 2016, where we don't have any tests. And what had happened during that time, he didn't think he had glaucoma, and he'd kind of gone away for a period of time. And it was really only about right here where we were able to convince him that he really needed to take his or use his latanoprost. And so this is where I want to show you what happens when you reset the baseline. If we're going back and we're comparing him to 2012 or 2010, and we know that for a period of, say, 6 years, he hasn't been using his medication, we're always going to get that message that things have changed. We're always going to have this negative slope. But what I really want to know is, since he finally got on board with this therapy, have we been able to slow this down? And so what you can do in your instrument or through Forum, you can go in and change the baseline so that now we say, okay, since we got him on his therapy, what's happened? And when we do that, what you see is really quite a flat line. Now, his nerve fiber layer is much thinner now, right? Because we know that he had that progression during the period of time when he wasn't using any therapy. But now, when we look at our thickness, when we look at our deviation maps, and when we look at our trend lines in both the right and left eyes, we have a much flatter curve. And we can say, I think with a lot of confidence, that we've got this patient in a position where I think he's going to be fine for the duration of his life. We can do the same thing with his visual field. So we now go to a 2016 visual field as our baseline, because that's when he finally agreed to sort of start using his medication. And we can see that his visual field in both eyes has really stabilized. We can also use a structure function map. This is in Forum. And so this is his right eye. If we take all of the tests into consideration, and if you look right here, there are these little dots right here. If you hover on this while you're in Forum, you'll see a little message that says patient finally started using his drops, essentially. And then when we change that, we see that everything looks much more stable over the course of the last 3 years since he got on board with his therapy. All right, that's a lot to go over, and I went over it pretty quickly. Mark and Rich, do you guys have anything to add?
I think you did a beautiful job with that case and really highlighting the value of reestablishing a baseline. You know, you're looked at his age, you start 86, so I think when you started presenting it, I kind of was wondering, especially when you were showing, you know, the visual fields and what looked like rate of progression, you could kind of see on a visual field if you reset the baseline what would happen. And I think you did a nice job of, once you do that, the fact that he really is fairly stable. So I think that was just a beautiful, beautiful case, highlighting all those important things you have to consider. Just as you said, trend analysis, how quick is he progressing, reestablishing baselines, et cetera. I think it's critical.
I agree 100%. And I would just add, the one thing that I'd be concerned about is that he has pseudoexfoliation. So I never let my guard down with those patients, but thankfully after you got him on treatment, it looks like you've really stabilized his disease. That's a beautiful case.
It's interesting, you know, he's a patient that I was very reluctant to treat at first because I thought, you know, he is quite old, and I thought, you know, he's going to be fine, but he's actually a pretty healthy guy. And once his pressure started to go up, I thought, you know, probably we should check this, or we should treat this, I should say. And then, you know, he really did seem to start having that progression that we anticipated. And we were able to finally kind of slow it down by getting him on board with his therapy.
Yeah, thank you. My colleagues really set the stage for me to finish up here, and I've been asked to talk about masqueraders, and there will be some overlap between what both Drs. Dunbar and Morelli talked about, but I think that that will probably be a good redundancy. Oftentimes when we think about clinical masqueraders, we usually think about a clinical condition that mimics other conditions. And of course, syphilis is usually the one that comes to mind as the great masquerader. But my experience with glaucoma is you have masqueraders, other optic nerve diseases, and if you're careful, I think most of the time, not always, but most of the time, you're able to pick those things up well. What I find in glaucoma is that the masquerader is often a misinterpretation of an OCT or certain measurement, and I use quotes there, measurement errors in OCT. So that's how I'm going to come at this. I want to look first at the OCT related masqueraders and then look at a few conditions that mimic glaucoma. And as I say, there will be overlap between what we've already heard. The first thing is very simple, is that if you're not careful and you don't look at the output of the instrument, image degradation can take place for a lot of reasons. And so you're going to have garbage that you're trying to make decisions on. So eye movements, blinks, dry ocular surface can all do this. Mark gave a beautiful example before. Media opacity, in his case a Weiss ring, cornea opacities and lens opacities can also degrade the image. So here's a patient somewhat similar to Mark's. Here's the Weiss ring, which will affect the thickness measurement right in this region. Here's just another patient with a smaller Weiss ring or partial Weiss ring, which you can see right here. And you can see how it degrades the segmentation. And here, and when you look at the T-SNP curve as well, you see a drop off down here in the right eye. And again, Mark went over that very nicely before. Disc size is important. And again, this was alluded to, and I'll look at it a slightly different way right now. This is an average sized optic nerve. And if you remember that this circle, the calculation circle, is centered on the optic nerve, and that's what generates all of our measurements in our T-SNP curve. So in an average sized optic nerve, we have the circle sitting in what we might consider an average position. Here's a large optic nerve, and as you can see, the edges of the optic nerve are much closer to the calculation circle. And if you think of the anatomy, as we get closer to the optic nerve, we recognize that the nerve fiber layer will get thicker. So as such, typically in large optic nerves, you will have an over measurement or a greater thickness of the RNFL than if the optic nerve was of an average size. And if we flip over to a small optic nerve, we can see that the circle is further away than the borders of the optic nerve. And as such, we have a tendency to underrepresent the thickness of the retinal nerve fiber layer. So that has to be taken into account when you interpret the results of your scans. How about segmentation errors? And again, this is kind of one of those algorithm things that Mark talked about before. Now, if you don't really look and then you decide, well, let me look at the T-SNP curve for the neuroretinal rim thickness here, you have to say, what the heck is that? I've never seen an optic nerve that looked like that. And, you know, look at the cup here and here. They're kind of really funky looking. But if we look at the tomograms, and I urge you to always look at the tomograms, you could see that this patient has huge Bergmeister's papillae in both eyes, which are completely fooling the optic nerve as to where the borders of the nerve are. We can't blame the OCT for that. We can only look at the way the OCT works, and the OCT is going to be looking for differential reflectivity to segment out layers. So it can't do it in this case because of these huge Bergmeister's papillae. So I urge you to always look at the tomograms to ensure that the OCT is measuring what it's supposed to. And you can see here it follows the contour of the nerve in the cup very nicely in both the horizontal and vertical tomograms. You can look to make sure that the Brooks membrane opening has been placed in the appropriate place, because that's how the OCT is determining the borders of the optic nerve. And then look at the RNFL tomogram, which is going to give you the T-SNP curve and give you all of the measurements that you're looking at. And you can see that it very nicely segments the retinal nerve fiber layer. And notice how thin the RNFL is in this patient who has a very nice wedge defect. This is a patient I saw just a couple of months ago, and I found her to be very interesting. She's a 58-year-old African-American woman with a family history of glaucoma and a pressure that was either 13 or 14. And she was sent in as a referral. She had already begun treatment on a prostaglandin analog. So let's just take a look at her. This is what Danica had showed you before, the structure function analysis. But there's sort of one thing missing on the structure function analysis, and I urge you to not forget about that step, which I'll tell you in 1 second. So if you look at her 24-2 visual field, well, it kind of smells of on the pattern deviation of a nasal step. She's got this whopping inferior arcuate scotoma, or partial inferior arcuate here. And if you look at her OCT in the left eye, you could see this huge wedge defect. Remember, this is a woman with a pressure of 14. She does have moderately large cups. But if you look at her OCT in the right eye, you say, well, this doesn't quite look right. Look at the monster thickness here. The disc looks funny. The scan itself just doesn't look the way a normal OCT looks. So when I first saw this case, I was trying to figure out what was going on. And then I said, geez, there's something about that right eye scan that perhaps we need to look at a little more carefully. And so when we looked at the tomograms, you could see that the tomograms have the appearance of what we see in highly myopic patients. They're kind of on an angle. You could see here, so I think this patient has a bit of a staphyloma on the macular scan as well, right here. So we measured her axial length, and you could see that she's about 2 millimeters longer in the right eye than the left. So she's got a myopic right eye. Her refraction was a little bit more myopic in that eye, but the actual length of her eye plus the staphyloma completely threw off the OCT scan in the right eye. Now, I will admit, I really don't know what's going on in her left eye. We saw her twice, and of course, she's been lost to follow-up, but I'm not convinced that this woman has glaucoma. How about signal strength? Murray Fingerette gave me this case. It's a nice example of the effect of signal strength and how this can masquerade as glaucoma. If you look over here, you can see, we talked about this before, that we've lost the saturation of the colors superior. And in both eyes, they don't have that real robust red and yellow appearance to them. There is a wedge defect here. There are wedge defects over here as well. But the patient blinked a few times, some artificial tears were instilled in the eye, and the signal strength went from 3 to 8, and we usually like to see a signal strength of 7 or better on the Cirrus OCT. And notice much more robust RNFL colors here and here. And although the wedge defects are there, they're not as pronounced. And I think the scan on the right is much closer to what's really going on in this particular patient. We talked, both doctors, Dunbar and Morelli, talked about measurement variability, and I want to make a mention of it as well. So here we have a scan of a RNFL scan or disc cube scan on the left and a macular scan on the right. And both doctors alluded to the variability on OCT scans. Mark talked about he likes to take 2 scans at the first visit. But you can get a sense of what's built into the instrument in terms of variability of the measurements. And sometimes that can be very important. If you hit this little triangle over here, it opens up a wealth of information, and you see it right here. So for all of the parameters that are measured, both for the disc and for the macula, you can get a lot of information. You get the normative data, the percentile value of the scan for that day, but it also tells you the reproducibility of the measurement. So if we look at the average thickness, which that day was 79, we know that the typical reproducibility for that measurement is actually pretty tight. It's about plus or minus 3.5 or so. So typically, if you get a measurement of 79, you could be pretty confident that it's really somewhere between 75 and 82. So that's a pretty tight measurement. If we go down to clock hour 7 down here, you can see that at clock hour 7, there's a lot of variability, and that's a very important region for glaucoma. It's a region that's inferotemporal. So we have a measurement that's important to our decision making, yet it has much more variability than the average thickness measurement. If we come over and look at the macula, you can see that the average thickness measurement of the GCA or the GCL-IPL measurement, you can see it's actually about plus or minus 2 or just a little bit more. So that's an extremely tight measurement. So if you think about what was said before, when we see change more than 2 or so in the macular average thickness measurement, we might anticipate that that's real change. And that's important to remember. Inferotemporal, it's only plus or minus 3. So again, the measurements in the macula are very, very tight. And I just want to look at a case like this. We've kind of seen this before, but it's just a follow-up to the case that Danica talked about. Here's a patient, and I want you to just think about this patient as you're seeing him for the very first time. And we won't go into his age because that, of course, always affects our clinical decision-making. But if we look at the patient, we can see that most things are in the green. So he is statistically normal. His T-SNP curve looks good based upon what we said before. The colors aren't all that saturated, but they're not terrible. And his macula looks mostly okay. But let's go back to his original exam 7 years prior. And this is kind of very similar to the case that Danica showed. Notice the saturation of the colors. We've lost that saturation. So if you saw him on this date, let's say he's moved into your area and he's become your patient, then you wouldn't have recognized that he has actually lost a fair bit of his retinal nerve fiber layer. And here is the progression analysis, which Dr. Morelli already talked to you about. So, we always have to remember that glaucoma is a progressive disease and that we need to make sure that we follow these patients carefully over time. Okay, other masqueraders. This is the tough guy, high myopia. To me, the hardest cases that we see in a glaucoma service, because high myopia is a known risk factor for glaucoma, but it's also a confounding factor in the diagnosis of glaucoma. If you look at these nerves, all right, this patient has large cups, but the nerves are tilted. There's lots of peripapillary atrophy. The rim looks funny. And if this patient were presenting for the first time, you may wonder, am I looking at glaucoma or am I just looking at high myopia? She made our lives easier. I've been seeing this patient for 20 years and her pressures were in the 20s to start with. So she made it very easy. But think about this case if the pressure was 12 or 13. And at SUNY, because of our contact lens clinic, we see a huge amount of high myopes and high myopes who are also keratocones, who are very, very difficult to deal with because they have these funky optic nerves. This happens to be her disc cube and her macula cube, and not surprisingly, you can see that the RNFL is quite thin. But again, the question is it quite thin because of myopia, or is it quite thin because of glaucoma, or both? And so following the patient over time is, of course, important. Dr. Dunbar mentioned before that you have to be very careful about using the reference database or normative database on high myopes, because none of them are included in the typical reference database on any of the OCT instruments that are out there. And so if you're comparing somebody who's a -10 to a reference database that includes nobody like them, then you could really get yourself into trouble. And this was a really nice paper that came out of the Journal of Clinical Diagnosis and Research, not an eye journal, but looked at OCT imaging of the retinal nerve fiber layer in high myopes. None of these patients had glaucoma. So essentially what you have is two groups, a group of high myopes greater than -6 and a group of emmetropes or close to emmetropia. And they compared the RNFL thickness between the two groups. And look what you find. The average RNFL thickness between the myopia group and the emmetropia group was between 18 and 28 microns. So the myopes who did not have glaucoma had RNFL thicknesses that were hugely different than the emmetropes. And you could see here in the important glaucoma areas, even a larger spread in the superior and inferior areas. So when using OCT to look for glaucoma in high myopes, I would be very, very, very careful in using reference databases to help you make the decision. So some strategies in evaluating high myopia is, first of all, just measure axial length, because the longer the axial length, the greater the effect on the OCT imaging and the retinal nerve fiber layer thickness. And as Mark already said, recognize that your OCT and your visual field, because the visual fields are often funky, they may not be useful. Look for progression over time. And I probably should add to this that there seems to be some evidence that looking at the macula may be more useful in separating high myopes without glaucoma from high myopes with glaucoma. So high myopia really is a masquerader. This will make you feel better, though. This is a paper that's come out that showed us that normal tensive glaucomas with myopia seem to have a slow progression rate even without being treated. So if you're not sure and the pressures are normal, you may be more comfortable in not treating those patients, but just watching them over time. Disc tilt, and this goes hand in hand with myopia. Disc tilt is also going to affect the OCT measurement. So we have a high myope up here, and you could see that the disc is tilted, and that may affect the relationship of the disc to the fovea. And we know, even though we always think that on average, the center of the optic nerve is 5 to 6 degrees above the center of the fovea. And on average, that is true. But there is a huge variability. So I think it is very prudent to look carefully at the relationship between the center of the nerve and the center of the fovea. So that kind of makes you look at the images themselves, which I think is going to be one of the next trends in OCT imaging. We're going to start looking more and more at the actual B scans. The blood vessels also play a role. If we look here, we can see this patient seems to have a wedge defect. This is just about the last patient I saw at SUNY before we were essentially shut down. But I want you to notice here that although this does appear to be a wedge defect, look at the blood vessels. We would anticipate that these blood vessels would be coming out here. There's some situs inversus here. And so the positioning of the blood vessels and the fact that blood vessels add thickness to the RNFL are also going to affect our ability to appropriately interpret the OCT. And if we look at the T-SNP curve, this is the left eye, here's the right over here, but look where the peak is. It's way over here at supraonasal, because that's the greatest thickness over here. It makes this eye look incredibly asymmetric, yet it's asymmetric more because of the situs inversus that we're seeing in the left eye. So start looking carefully at your blood vessels and their positioning as well when you look at your deviation maps and thickness maps. Epiretinal membranes. Now we're imaging the macula more and more. So again, if you don't look at the images and you're not careful, then you're going to think that you have a change in the macula when you don't. And this is kind of a typical appearance that we see in the macula scan from an epiretinal membrane. It kind of almost reminds me of a propeller sometimes. So, you know, this type of change does not really make any sense, nor does this, until you realize that the patient has an epiretinal membrane. And I saw a real nice one in Optometry Times, and Ben Casella, who was a former resident of mine, so I figured I'd give him a plug here. Ben put this case out there, and it's beautifully shown. And again, this makes no sense. This doesn't look like glaucoma. But what you have is an epiretinal membrane tugging on the surface of the retina and therefore changing the measurement of the GCL IPL. So don't miss epiretinal membranes and confuse them for macular glaucomatous changes. And now I want to shift gears a little bit. So those are kind of the masqueraders that we see from the OCT. Here you have a 75-year-old man who shows an inferior altitudinal field defect in his right eye and some glaucomatous appearing changes in his left. So when we think of altitudinal field defects, we do think about NAION, and that's exactly what this man has. He has NAION. I want you to think about this, because this is a two-way street where NAION can be confused for glaucoma, but glaucoma can be confused for NAION. This is taken from the optic neuropathy decompression trial. And you could see when they looked at the field defects in their patients, as many had superior arcuate scotomas as superior altitudinal scotomas. And it wasn't quite as equal in inferior, but there's plenty of inferior arcuate scotomas that can look like glaucoma. And a lot of central scotomas were found in NAION, and probably we would find less of those in glaucoma. So if we're trying to differentiate, and this is where we get into the masquerading part, if we want to differentiate glaucomatous and non-glaucomatous optic neuropathies, always consider a non-glaucomatous etiology if the clinical picture does not make sense for glaucoma. Look at the disc carefully. Pink usually signifies glaucoma, certainly in early glaucoma, versus pallor that we see in the early stages of non-glaucomatous optic neuropathies. Make sure the disc correlates with the field and vice versa. Look for field defects typical of glaucoma, which we've described to you already. And typically in glaucoma, we don't see visual acuity changes, at least in the early stages of the disease. And here's a pink optic nerve for glaucoma and a pale one from a patient who has non-arteritic ischemic optic neuropathy. I just want to end with this, because these are starting to become masqueraders, and I'm finding them fascinating, and I want to share them with you. We have a very active head trauma clinic, and we have seen a number of these patients, and I am sure they are out there, but we've never looked before. This was a TBI patient, also referred as a glaucoma suspect. So let me just tell you what you're looking at. The right eye is on the right, the left eye is on the left. I'm going to show you the visual fields, and you could see that he has a hemianopic field defect. But let's just walk through this. He has a right hemianopic field defect, which means he's got a left brain head injury in this particular case. So if we think about if his problem is in his left brain, then the temporal fibers in the left eye are uncrossed. So those are represented here, and you could see thinning right here. And the nasal fibers in the right eye are going to be, or crossed fibers, those are the ones that have gone to the left brain, those are represented here. What we typically see in glaucoma, as mentioned before, is this inferotemporal wedge defect, which I think he has. I think he probably has glaucoma also. But this is not what we see in glaucoma. And we are starting, because we're starting to see these more commonly. I just put in a horizontal RAF-A for you and a horizontal midline. And so if we take these OCT images and flip them over, you can see that these line up so nicely, pronounced more rather, in the macula as opposed in the circumpapillary retinal nerve fiber layer. So I find this fascinating, and I would ask you to look for these. And here's another patient of mine she doesn't have a pronounced field defect, but she has what I'm starting to call a structural hemianopic field defect. So we're seeing these. Start to look for them in your head trauma patients, your concussion patients, and you may be surprised what you find. And if they have large discs and suspicious nerves, as both of these patients were, they can be very confusing and act as masqueraders. So that's it for me. Thank you. And I'll open it up to my colleagues for any comments or questions.
Well, thank Rich. I mean, that was a lot of information over a short period of time, but I think you've summarized all the difficulties we sometimes have when you're, doing OCTs just on a number of patients. These things that all of a sudden come out at you and you're trying to answer the question, is it glaucoma? Is the abnormality that I'm seeing on the OCT from glaucoma? And I think the answer is, part of it is you just have to do a lot of these. And the more experience you get, very quickly, you're able to kind of weed through some of those things very quickly. But as you pointed out, the tilted nerve, the high myope, some of those things are really, really difficult. And again, I think we're programmed to want to know the answer on that visit right now. But with glaucoma, that's not always the case. Sometimes you just have to wait it out. You repeat the test, you put the information together. And again, I think we all recognize, to be able to have all of those pieces of the puzzle, to be able to make these decisions, and hopefully the right decisions, and then help guide us. Is it getting worse? What is that rate of progression? I think is really, really valuable.
If you do enough glaucoma and see enough glaucoma patients, you begin to realize that many of the patients who you find are sitting right on the border, that you follow them long enough and they never change. And when you see enough of those, you realize that time really is on your side. If they change, you can act. Danica, I don't know if you have anything you'd like to add or...
No, I think you did a great job of covering the masqueraders. And I think that it always goes back to that correlation of, does this make sense for this to be glaucoma? So the picture that you showed of the AION patient, if you just took that OCT in isolation, you might say, this looks like glaucoma. But when you put everything else together, you start to realize that it's not. So I think that it's a great example of how we shouldn't just be relying on one particular technology or one particular part of our exam. We really have to put everything all together. And it's okay to wait. It's okay to say, I'm not quite sure if this is glaucoma or not. I'm going to see this patient a few more times before I make that decision. Once you start that patient on glaucoma medications and you say you have glaucoma, it is really hard to backpedal off of that and take that patient off.
So I want to thank everyone, certainly my colleagues, everyone who is listening in to this, and we appreciate your time. We appreciate the invitation from Zeiss to put on this program for you today. Thank you very much.
Thank you all very much. Appreciate the time.